Good evening. My name is Jim Greenblatt, and I'll be talking with you this evening about OCD, Obsessive Compulsive Disorder, which certainly in my practice and work that I'm doing, I feel is increasing dramatically, both in young children and adults. And the reason I want to talk about this evening is because the traditional psychiatric treatment, I think, is often misguided. The diagnosis is often missed. The integrative treatment that is being discussed is often limited in its efficacy. So it is a very complicated disorder. To me, it is really what I call a true disorder that often needs integrative therapies, which would include nutritional support, biomedical testing, medications, and certainly CBT and psychotherapy. So let's start our discussion with the basics and the facts to help everyone kind of understand what we are talking about. It's classified as an anxiety disorder with two different components, obsessions and compulsions. Obsessions are the thoughts, we'll talk about it, and compulsions are the behaviors. OCD sufferers are aware that their thinking and behavior are abnormal, but feel powerless to change their thinking and behavior. This is very different than our delusional patients, thought disorder patients, schizophrenic patients, where some of their thoughts and behavior they don't see as abnormal. Most of the time, patients with OCD, unless it's very young children, understand that these thoughts are controlling a lot of what they're doing. The obsessions. Again, these are the recurring ideas, thoughts, images, or impulsive impulses. They're not behaviors, they're intrusive thoughts. Again, we recognize them as irrational. We try to suppress them. They can be stopped for minutes, days, or hours. Oftentimes, for many patients, they become intolerable, and they persist for long periods of time. The most common obsessions are what is in front of you. Contamination. Pathological doubt is often seen in children, early adolescence, and many people miss it because it's this constant need for reassurance, and parents really don't see this as an obsessional thought. Am I okay, Mom? Am I going to do okay? Do I look okay? Etc., etc. Aggression, sexual impulses, even in young children or the elderly, need for symmetry, bodily and somatic health concerns, thoughts and musical rhythms, and religious convictions. There are obviously many, many more. Again, the compulsions of the behaviors. These are the behaviors or rituals performed to dispel that anxiety. If you can't get the thought out of your head that you're going to get sick, and you'll constantly be washing your hands or washing doorknobs, etc. The most common compulsions are in front of you: accounting, needing to confess. This can be quite embarrassing at adolescents who've had to tell their parents every time they have a sexual thought, every time they masturbated, every time they did anything that they thought they shouldn't through teenage years. Hoarding, touching, checking are some of the common ones. The next slide here, based on the research, not necessarily based on my clinical experience, but based on the research, these are the most common obsessions and compulsions that we see in patients with OCD. Now, one of the most important things I can share with you as clinicians, patients, parents, family members, is that you do not have to have both obsessional thoughts and compulsive behaviors. For many years, so many patients suffered because they didn't meet the criteria in the book, in the early DSMs, where you had to have obsessional thoughts and compulsive behaviors. So individuals were tortured with one intrusive thought. And these individuals had no behaviors to compensate for it. People would say they did not meet criteria, and it really limited treatment, I believe. The way I look at OCD is that it's a spectrum, that there are many disorders that have subtitles and categorized in the DSM, including eating disorders, hypochondriasis, and body dysmorphic disorder. And I believe that these are all variants of the same neuropathology that we refer to as OCD. Not everyone who suffers from OCD experiences every symptom, and it's a waxing and waning course. Some people experience a few symptoms, others many, and this waxing and waning course, some to go a year without significant symptoms. They start and they can escalate. Someone might have one symptom for many years. I have a number of patients who had multiple rituals and obsessive thoughts as children, and they said, oh, I had OCD as a child, and they're presenting to very abnormal eating behavior. They don't see that the OCD neurochemistry, if you will, has translated to obsessional thoughts around food. The reason that I believe an integrated approach is so critical is that it is a treatment refractory illness. For many reasons, the second bullet here, the likelihood of complete recovery, has not been shown to exceed 20%. So when we do these research studies and we show a medicine works or a behavioral therapy works, what we're demonstrating is only improvement in symptoms. Oftentimes less than 50% improvement. So we check the box and say this medication works, this behavioral treatment works. Patients are still struggling, oftentimes suffering. Very important part of the treatment is understanding the comorbidities, the other coexisting conditions. We talked about depression, eating disorders, ADHD, many other anxiety disorders. And I've already shared my bias. Even though the literature states that eating disorders and OCD, there's a comorbidity of only 30%, in my understanding of the neurochemistry and in the treatment response, I believe the majority of patients with eating disorders, they are obsessed about food and their body and weight, all struggle with the same pathology that most of our patients with OCD does. And I've said this, but I can't repeat it enough. Obsessions may occur alone without compulsions. One of the places that I see this get very convoluted is patients who present with OCD and depression. They are, again, what we call treatment refractory depressed, and a poor response to medication, poor response to therapy. They're hopeless. Their family members are hopeless because they tried diligently to get help from professionals, from alternative treaters, but things don't get better. And part of what I found is part of their OCD is their obsession around their illness. It could be their cognitive thought patterns, this negative self-image is obsessional, and or their obsessional thoughts around the depression. OCD is common, what will common psychiatric illness. Its onset is usually in adolescence. There tends to be two peaks, one in childhood and one in late in adolescence. The OCD begins with 1/3 of the cases by age 15. It is interesting, it's one of the few psychiatric disorders that men and women are equally affected. This is a case that really got me very interested in pursuing a biomedical approach to OCD. It's a family that came to see me from the West Coast, multiple medication trials in a 7.5-year-old. They report symptoms by age 4. She thought she was fat. She was worried that others would get sick, constant reassurance. And even though the family was not religious, she was constantly praying and washing her hands. It was a family of OCD. We'll talk about her later on, but she didn't respond to medication, didn't respond to therapy, and only responded to some of the alternative integrative therapies I'm going to share with you today. And on a very depressing note, but I think a really critical place to begin is with a quote from Jeffrey Dahmer, who was a serial killer. I remember listening to this interview on Dateline with him and his father. And as he talked about his childhood, it echoed, if not identical, to the words that I hear weekly from young children and parents about what OCD looks like in pre-teenagers. Jeffrey Dahmer talked about being a normal child playing outside with friends, and then he reported having obsessive thoughts of violence intermingled with sex. It just got worse and worse. I didn't know how to tell anyone about it. He details the stories of aggressive impulses, and then before he was sexually active, having sexual obsessive thoughts, a classic case of OCD. And one of the things that I believe this biomedical approach is so incredibly helpful for is stopping this disorder in young children almost completely without medications. For the adults, been treated for many years and stuck in these thought patterns for many years, often we need to do many different kinds of things, but young children can be treated quite nicely with the integrative approach. And the reason I feel so strongly about this, and the reason why I want to start with this quote, is that if a 7 or 9-year-old child has these intrusive thoughts, whether it's about their weight, whether it's about violence, whether it's about germs, it is very difficult for them to distance themselves from these thoughts, for it not to affect their personality development, their cognitive style, and how they relate to the real world. So these young, early onset OCD cases, it becomes much more imperative that we aggressively treat, because then it does not become something that they're used to and see it as just who they are. Nobody really knows what causes this disorder. We've talked, like many psychiatric illness, the psychodynamic, repressed sexual feelings. There is a strong genetic link. There's clear abnormalities in serotonin. But what is clear is there's no theory that's sufficient to stand alone. The genetics is, I think, quite striking. Again, we see these genetic liabilities. They might not be pure OCD. It might be a very adaptive OCD individual who used the OCD to be a successful businessman, or a computer person, or other fields where the obsessive traits have been very helpful. It could be someone with just compulsive behaviors without making a diagnosis. It could be the aunt or the parent who just has to leave house and folds towels every 10 minutes and washes the furniture every time someone sits down, but never treat it. It's critical that you take 3-generation family history as to obsessive thought process and compulsive behaviors. Don't always say, is there a family history of OCD, because often we get a negative. The integrative therapies that we look at is the same I look at for any psychiatric illness. This is not all of them, but certainly nutritional, mineral, vitamin, hormones, infections, amino acids, heavy metals, fat, cholesterol, environmental toxins, and CBT is behavioral therapy. The ones I'm going to focus on tonight is folate B12, 5-HTP, Inositol, overgrowth of Clostridium metaboli, and production of HPA, poor digestion of dairy and gluten, and how to use reference EEG for medications if needed. Treating OCD because of the profound genetic liability as well as the behavioral template that gets set in place once someone starts these behaviors, it is usually not a simple deficiency that is treated with one supplement. Frequently get asked about PANDAS. It's an acronym for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Stress. I'm not going to talk a lot about it. It would be a long discussion in itself, but it is clear, and there's been webinars on it, and I think there's some good information on the Great Plains website about how infections can mimic many neuropsychiatric illnesses. PANDAS, for many kids, we've been able to show an association between strep infections, the sudden onset of OCD, and tics. Oftentimes these are pre-pubertal kids. The onset is usually sudden, and treatment for strep with antibiotics can be helpful. There was certainly a major discussion in Roy High School in New York. To me, this was fascinating only because the week that was on, I saw a number of kids in my office with very, very similar tic, OCD-like behaviors that I was treating, medication and through nutritional support. So when these neurologists talked about mass psychogenic illness, it was to me a real disgrace to the field of psychiatry and a real disgrace to these kids and families. Clearly, stress has a role in all psychiatric illness and in infectious illness as well. Dr. Trifoletti also saw many of these kids. Many of them tested positive for strep with improvement with treatment. The diagnosis was debated, lots of confusion. I think it's quite clear to me there was an infectious part to it. I think as you open up the PANDAS door, you realize that strep is one of many infectious agents that could trigger this onset. So there are many other kinds of bacterial organisms that we are looking at that could be triggers for OCD, tic-like behavior, even depression and schizophrenic-like illnesses. But for purposes tonight, clearly looking at infectious etiology is an important part of the differential for OCD. So our treatment is pretty much a behavioral therapy. Behavioral therapy has been shown to help, has also been shown to make changes in the brain based on PET scans. It's a very expensive, timely, 3 to 5 times a week therapy that very few people are trained in. Medications that enhance serotonin has been shown to be helpful, but again, the studies are so limited in that they were only looking at minimal improvement. 80% of patients improve, but the reduction is 50% or less. Again, the SSRIs, anaphranol, tricycline, all those medications that increase serotonin are the only ones that have shown some benefit. I do need to kind of share with you that this illness is so debilitating that in the New England area, Mass General Hospital, and Brown Medical Center are using psychosurgery. Patients are so tortured by these intrusive thoughts without help from medications and any other treatment that these centers are doing psychosurgery for OCD, and it is increasing. I just would give you a little historical background on psychosurgery. The prefrontal lobotomy was the most common procedure used in the 30s and 50s, and the Nobel Prize was actually awarded for Dr. Moniz, who discovered this. And he was actually shot and killed by one of his frontal lobotomy patients. So I understand the pain many of these patients are suffering, but I hope we can look through some of these integrative approaches before we look to surgery. This is a brochure. This is a brochure, I believe it was from Brown University, psychosurgery for OCD. We don't like to call it psychosurgery. It's neurosurgery for severe illness. So the first place that I think makes sense to start is understanding this concept of a likely either deficiency or abnormality in serotonin metabolism. We know there's benefit, and the work that I've done enhancing serotonin through medication and nutrition works does put a tremendous damper on this illness. There are many ways one could get to serotonin deficiency or imbalance. And these are just 5 of them. I think in our field of integrative medicine, people kind of get stuck to one concept and focus on it, but it is more complicated. So genes, we can test for our serotonin receptors, we can test for the serotonin transporter genes, and we can look at different variations in how we metabolize serotonin. There's profound genetic differences. Some of these polymorphisms we can test for, and it's now a routine part of my practice. Others we haven't even discovered or we have not put into routine testing. Diet, we'll talk a little bit about diet, but without adequate amino acid precursors, you're not going to be able to synthesize serotonin. Stress. Stress causes severe depletion of our neurotransmitter system through lots of mechanisms. One that's most common is inflammation, and how stress causes this increase in cytokines, which then goes on to break down tryptophan and serotonin in the brain by enhancing the enzyme IDO. We've talked about this in other webinars, but stress and inflammation from any source can have dramatic effects on levels of serotonin and can be the key to understanding this disorder. And then I believe the most complicated is neurotoxins. The hundreds of thousands of environmental toxins in the environment, in our food supply, in our water supply, that has a profound significance on brain chemistry. We're just beginning to understand this. The point here, many different environmental factors can affect the balance and or the function of neurotransmitters in the brain. But that's where we're going to start. Excuse me. If we're looking for serotonin synthesis, we do know that enhancing tryptophan in the diet can enhance serotonin synthesis, but what happens is there's a feedback mechanism in the brain where you only absorb so much tryptophan and it competes with other amino acids. So oftentimes we use the precursor molecule 5-HTP, and we'll talk more about that. But what you see in this diagram is a tryptophan goes on to make 5-HTP, which goes on to make serotonin, which is released into the synapse and then taken up by the postsynaptic neuron. If you are eating all the turkey and milk and eggs in the world, but if you don't have adequate digestion, meaning specifically hydrochloric acid and pepsin to break down the protein, then you will not be able to synthesize adequate serotonin or neurotransmitters. This is such a common problem, particularly in the elderly and in many of the adults I'm seeing. I see this most frequently. You've heard me talk about people that are walking into my office that are health food fanatics. They're eating their perfect meals of high-quality protein, but when they're depressed, they're anxious, they're OCD, and we look at the levels of amino acids, fasting levels of amino acids are all low. That is either because of genetic reasons, taking antacids, or I believe chronic stress, and not producing enough hydrochloric acid to break down protein to make these tryptophan available for serotonin synthesis. In our little diagram, we talked about using 5-HTP. We've been using it for many years in the treatment of OCD. This direct missile analogy is that there's no competition. It easily crosses the blood-brain barrier. Unlike tryptophan, it's not converted into D3. It's not converted into proteins. It is only converted into serotonin. So as we increase levels of 5-HTP, we would only increase the levels of serotonin. We'll talk about potential side effects in a minute, but the other important piece that you hear me talk about a lot are these cofactors. Again, our patients might be eating adequate amounts of the protein or amino acids, but either genetic defects or dietary deficiencies in folate, B6, zinc, or magnesium, and one is not going to be able to synthesize adequate amounts of serotonin. So I've worked with pure encapsulations and it is available at New Beginnings of a number of supplements, but this one in particular for helping enhance serotonin is called SeroPlus. So if you notice there's 5-HTP as well as all the cofactors, folate, magnesium, and niacin, and we're going to talk about later Inositol. And in my experience, I found this to be more helpful than just adding 5-HTP on its own, although for years we did just use 5-HTP with the cofactors as separate supplements. I'm going to focus a little bit about the research on folate because it's quite striking. We can use words like double-blind placebo-controlled trials. We can use words like Harvard Medical School and academic peer-reviewed journals. But we know the literature on depression is quite striking, and I think most of that literature can be translated to OCD and certainly the enhancement of neurotransmitter synthesis. We know folate is associated with increased incidence of depression. We know patients who did not respond to an antidepressant had a much better response with adding folate, and then dramatic studies were done looking at relapse rate. These studies show that those with the lowest levels of folate had the highest relapse rate for depression. And also studies, particularly in women, that folate enhanced the effect of the depressant. The diagram really just helps us understand that folate is converted to L-methylfolate, and through homocysteine metabolism makes SAMe. And SAMe donates a methyl group to all the major neurotransmitters, the catecholamines. Our interest today is in the bottom one here, serotonin. So without adequate L-methylfolate, we're not going to be able to synthesize adequate amounts of serotonin. Folate is critical to understand because I believe it is complicated because it is added back in our food supply as folic acid, and we're seeing very, very high levels in the blood. But we're seeing very, very low functional markers for folate. So it's lost by cooking and canning and processing. Many of our patients taking antacids, GI problems are not absorbing folate, and probably the most dramatic with the genetic difference in how we metabolize folate. So they're varying numbers, but it's 5, 10, or 15% of the population have genetic polymorphism for folate metabolism. We'll talk about that. And what is also striking is the number of medications that affect folate. And here are just some of them. All the anticonvulsants that we use in psychiatry: alcohol, antacids, antibiotic, metformin, and birth control pills. And there are many more. Most of our drug-nutrient interactions are really not documented well, and we don't understand it. But folate seems to be particularly sensitive to many of these medications. Again, folic acid requires first steps to make L-methylfolate. L-methylfolate is the form that crosses the blood-brain barrier. It is the form that I would recommend to all my patients. I try to get multivitamins that have only L-methylfolate, and I supplement with only L-methylfolate. One, because it overcomes this genetic polymorphism, and two, because I believe there is some concern about supplementing with high-dose folic acid. So this genetics is quite striking. We're able to look at this MTHFR gene. There are 3 variants: normal, CT, and the TT you see here on the slide. The one variant, there's a 1.36 times greater chance of developing depression, and the TT type is twice as great. That's pretty dramatic, twice as great the risk of developing depression, and I think for our purposes, again, our ability to metabolize folate is critical for understanding the synthesis of serotonin. We have found a direct association between these polymorphism and numerous neuropsychiatric illnesses. A simple blood test that I do on everyone that comes to the office is looking at homocysteine levels. I do not believe that folate levels are very helpful. When you do see a low level, it's pretty dramatic, and I would supplement aggressively. If you see a normal level or even a high level, we see this all the time. It's mainly because of all the added folate in our processed foods. But what I'm seeing is that it is not crossing the blood-brain barrier. It's not being converted to L-methylfolate, so it's accumulating in the serum and not providing the needed neurotransmitter support. I just want to take a few minutes to talk about B12. I rarely would use folate, particularly high-dose folate, without high-dose B12. Oftentimes we see them together deficient, but here, just one example of how significant B12 deficiency is. An elevated homocysteine was one of the markers increasing the risk for Alzheimer's and dementia. Here's a great book on B12. I think what's most helpful about some of the writings here is helping people understand that the serum levels of B12 are not an accurate measure of B12. We look at many different variables. We look at methylmalonic acid in the serum as well as the organic acid to assess B12 levels. What is dramatic in my practice is B12 is not consistently deficient in one neuropsychiatric or even physical symptoms. There are patients that have just the same B12 level, have just a physical or neurological symptom of weakness or clumsiness. Others could have anxiety, with OCD being a major component of that. To me, B12 is such an important part and one of the most consistent deficiencies we see in OCD. Let me do this slide first, that of all the physical and neuropsychiatric symptoms, these are the most common that I see in OCD, and anxiety is certainly part of that. This was just a striking study looking at B12 status and brain volume, and the lower B12, even when these were in the normal range. And that is what is so important to understand. Every day I see patients that have been told by their primary care doctors that their B12 is fine, they feel miserable, and they have a level of 230 or 250 or 400. I believe all levels should be close to 1,000, and even our laboratories, this is a quote from Quest Laboratories, their reference range is 200 to 1,100, but they at least acknowledge the subset that have symptoms between 2 and 400. Even though this is written into the lab report in fine print, patients or physicians do not read it, and they're telling patients with B12 levels of 3, 400 that they're fine. Seeing such dramatic improvement with B12 supplementation with levels of 3 and 400. Again, I try to get patients up to at least 1,000. And with symptoms like fatigue, anxiety, OCD, I would treat regardless of serum levels. B12 is safe, it's not toxic. We had very good studies in dementia patients where they had a normal serum level, but incredibly deficient brain levels of B12. Excuse me. So serum levels are helpful, but often I treat empirically. I used 1,000 or more of hydroxy or methylcobalamin 2 to 4 times a week, often for many months for patients. I want to talk about inositol, and then I'll go through some cases and specifically some testing. And inositol is an incredibly helpful nutrient, and if you remember our serotonin slide, where serotonin is made, the presynaptic neuron crosses the synapse to have an effect on the postsynaptic neuron. Inositol actually acts as a second messenger, which means what serotonin does in the postsynaptic neuron is create inositol by releasing it from this phosphodilyl inositol in the membrane. So serotonin actually is enhancing the release of inositol. So what we've shown in the research, and inositol is looks like glucose, and so it's sweet tasting, so very easy to give. So the research since the late 70s have shown it very, very helpful in the treatment of depression and the treatment of OCD. I'm going to go through these quickly because we're running a little late, but the good research on depression. But here for our purpose today, American Journal of Psychiatry, 1996, 18 grams of inositol. Now that's a lot. It's 6 teaspoons of most of the powders of inositol that is used and sold, the pure inositol. This dose was randomly picked. I oftentimes don't need as high a dose for the treatment. But in this small double-blind placebo-controlled trial, we're able to see a positive effect comparable, without side effects, that the treatment of OCD. The inositol literature is important for a couple reasons. Here's another study where the inositol was added to the SSRI in the treatment of OCD, and they did not get a significant difference. I would say my clinical experience has been mostly the same. Occasionally, I do get enhancement of the antidepressant by adding inositol, but I usually use one or the other because the effects are the same, particularly the SSRIs. I have found inositol incredibly helpful for Wellbutrin supplementation because the inositol is providing a little of the serotonergic effect and Wellbutrin the dopamine and norepinephrine effect. So here's the last study for OCD that it did not lead to, just summarizing what I shared with you, in the majority of patients, but 3 of these patients did report a clinically significant response. So statistically, this study showed that you did not get the augmentation. So the study was negative, but 3 patients clearly did. So the mantra that I hopefully can't repeat enough is this concept of biochemical individuality. Everybody is different. An augmentation strategy of inositol cannot hurt. So in summary, for inositol, almost all the disorders that have been studied that does have a positive effect with enhancing serotonin has been shown to be somewhat helpful, and this includes OCD, panic disorder, bulimia, and depression. Okay, let's go through some cases so you can begin to see how we use it. This was a child. I was seeing a relative. I brought their 11-year-old. He was worrying as a child, but was considered just as my family anxious, but doing well in school, not in any kind of psychotherapy. Saw a movie at age 11, started developing very, very profound OCD symptoms, fears of fire in the house, not able to sleep, not able to get to school, and inositol was the sole treatment for this 11-year-old child. You know, within 3 months, pretty much back to herself, and the supplement was actually tapered in 6 months. And I stayed in the family for a couple of years because of the daughter, and there's no further treatment needed. Again, an anxious, obsessive child, but not the clinically significant OCD. This was stopped in its tracks. This patient, again, you see the dose of inositol is not as high as most of the studies. Again, the studies were done with adults, but they were often 18 grams. We used much, much lower doses. So here you see the inositol at 4.2 grams, and this child, we did use 5-HTP, and the 5-HTP was 150 milligrams per day. This was, again, another patient that I followed for a while, and ongoing significant improvement. This was another patient that came to see me out of state. Same kind of 7-year, I started at age 7, onset early on, not throwing away garbage. This is a child who brought soiled toilet paper and garbage in her backpack home from school. Again, a positive family history of OCD in this child. If you notice, multiple trials before I saw them of the SSRIs, agitation, aggressive behaviors with Prozac, attempted suffocation with suicide attempt. There was a 40-pound weight gain on the SSRIs and the Sluxy before the suicide attempt. I not at 5-HTP, but did a trial of Inositol with some improvement, but not significant enough. But we did testing. This was actually one of the first cases that I did. It was in the mid-90s, and looked at elevated levels of casomorphine and gliadorphine. And what we found in the 90s is young children, in particular with OCD, had elevations of these neuroactive peptides that were exacerbating or the sole cause of the OCD. So for those of you who don't know this, these are tests done looking at the urine test, looking for these two neuroactive peptides. Casomorphin is derived from the protein casein in dairy, and gliadorphine from wheat. As they sound, casomorphin and gliadorphine, these are opiate analogs. They react with opiate receptors in the brain and have profound CNS effects. Like morphine, though, they have different effects on different individuals. Early studies looked at autism and schizophrenia. But these elevations in these neuropeptides have been found in postpartum depression, celiac. I've been repeatedly seeing it in eating disorders and OCD, ADHD, dyslexia, as well as, again, the early studies in on autism and schizophrenia. Individuals have a unique response to neuroactive peptides, but it is a simple urine test that one needs to do on anyone presenting with this disorder. This is just an example. Many of you have seen this slide. Patient began eating flour when she was 16. She couldn't recall being depressed, but she could not pinpoint the thoughts that led her to eat flour. She enjoyed the taste of it. She presented to our partial hospitalization program for eating disorder. At age 24, she was taking 1 to 2 pounds of flour a day, meaning she mixed it in water and ate that mush throughout the day. She had periods where she was taking up to 4 pounds of flour a day. She had, again, OCD, eating disorder, and trichotillomania. It's just an example of the profound effect of these neuroactive peptides. These are just some of the signs of patients that I have treated with OCD that had elevations of casomorphine. So these are just some examples. The first one is that whey protein powder. This was a gentleman who had a mild case of OCD, being treated by a colleague of mine, doing okay on medications, and he started a bodybuilding program when he went off to college. He was taking large quantities of protein powder from the health food store. It says whey, but oftentimes it's casein, or it's certainly cut with casein. And as he started bodybuilding and taking massive amounts of casomorphine, he started getting increasing OCD, where we had to hospitalize him because he had intrusive obsessive thoughts about wanting to kill his parents. He couldn't get those thoughts out of his head, and he needed to be psychiatrically hospitalized. As we eliminated dairy, those thoughts improved with no other adjustments in his medications. Now, the granola story is a patient with OCD who did much better eliminating casein based on the testing, but she had mild symptoms, and not until she eliminated her granola bars, which were loaded with casein, did she notice remission of her symptoms. The cheese is just to remind me that sometimes the casein is more concentrated in cheese. Often have patients, they drink dairy or have dairy, and they say no, and they don't think of cheese. Often it's dairy. Many people are addicted to the cheese. I've had patients had profound anxiety and OCD. I admitted they were addicted to cheese, but unable to stop eating cheese, even based on the testing and the work. Coffee Mate is another example of someone who was taking large quantities of coffee mates because it's concentrated casein, and OCD symptoms didn't improve. And ice cream, patient who had a bowl of ice cream every night because it helped her sleep, and until she eliminated, she didn't have dairy during the day, but until she eliminated the ice cream, her OCD got better. Just a few examples of many, many patients, particularly young children, were eliminating casein based on this corrected peptide. And just to summarize, casein is just an example. Cheese, milk, any dairy products breaks down a casein morphine. Let me just skip ahead for a minute. Casein morphine is a peptide that is broken down by the enzyme DPP4. This is a zinc-dependent enzyme that these morphine analogs are required to break down to these individual amino acids. So if casein morphine is broken down by DPP4, then the amino acids enter the brain, and we can make serotonin from our tryptophan. If we can't break down adequate DPP4, and casein morphine enters the cross-blood-brain barrier and can have an effect of increased anxiety and, for some, exacerbating OCD. Again, it's a simple urine test, and I have a line in my depression book, The Measureless Medicine, and how psychiatry is always guessing based on symptoms. But here's a simple test where we can look for a cause. This is a slide that Dr. Shaw developed, helping people understand some of the many variables that could affect the DPP4 functional efficiency and or productivity, both the vaccines, antibiotics, overconsumption of dairy, yeast, the heavy metals, and genetics interfere with DPP4. And I always share with you that this variable response to, and I want to share with you one patient who, asked me a year ago to if I could talk about her case so people can understand how profound this elevation of casein morphine can be. And also speaks to this blurred line sometimes to very severe OCD with schizophrenia. This was a young adult that I saw that in late adolescence had been hospitalized for many, many years, multiple times, and with the diagnosis of schizophrenia. She had multiple delusions, and many of them were simply intrusive thoughts. Some of them were thoughts that her shoes in her closet would hurt her. She didn't close her closet. Or her jewelry would choke her if she didn't clasp all the jewelry. And as this occurred since childhood and exacerbated in adolescence, she became debilitated, refractory to medication, saw me, which was taking over 9 psychotropic medications. And she had a significant elevated casein morphine. She was able to eliminate dairy. She was also able to take the DPP4 enzyme and do dramatically better. This is a case that that I was fortunate to follow. Now it's actually 7 years, as I see this year. This was last year. But again, refractory to medication, 7-year-old child, severe OCD, limiting her school and social life, intrusive thoughts about germs, about going outside, about storms. The only intervention was eliminating dairy, a profound difference. Over the first few years, pretty much dairy-free, back on a normal track with education, socially. This particular patient actually started reintroducing dairy, noticed an exacerbation of the symptoms. it was controlled enough where she was able to take the DPP4 enzyme with her. She went to a party where they did cake or pizza where she didn't want to be left out. And we found that if she took enough, sometimes with 4 or 5 capsules of DPP4, she'd be able to tolerate a small amount of dairy periodically. Showed the 6-year follow-up. I have not found repeat testing always to be helpful. The family was just interested. Here the ratio is normal, but again, it's not challenged with dairy. The patient on her 7-year follow-up is continuing to do well. A year ago, we did introduce Inositol, which she has continued to take. Because of a mild increase in obsessive thoughts about her fears of driving and stuff that she was seeing on TV. But pretty dramatic improvement again, poor response to multiple medications. And now I want to share with you a very, very severe OCD child, adolescent at the time, that did not have elevations of CASEIN morphine. So what I want to do now is just keep going back to the concept of testing and biochemical individuality. So we do this test on everyone, but Jake did not have elevations of CASEIN morphine, but he did have elevations of HPA, Clostridium marker, that I have seen associated with a broad range of neuropsychiatric illnesses, from psychosis to agitation to very severe forms of ADHD to agitated depression to OCD and anxiety. Very hard to predict. It does enhance the synthesis of dopamine and norepinephrine, so it doesn't intuitively make sense, but the only intervention in Jake, who has been seen all over the country for his OCD, the finest OCD clinics, never responded to any medication, but until we were able to decrease, actually normalize HPA without antibiotics, we were with high-dose probiotics, and within a year, complete resolution of, again, treatment-refractory OCD. Here, I'm going to go quickly. You can get a lot of this on Great Plains website, looking at HPA, metabolite of Clostridium that interferes with tyrosine and dopamine and norepinephrine synthesis. Okay, so now I want to present to you a 30-year-old with OCD. This individual did not have elevations in CASEIN morphine, did not have elevations in HPA, so, but did have very significant disabling symptoms, and were able to control with increasing doses of serotonin through, again, through supplements with 5-HTP and the cofactors. And then Andy is an interesting case. He came to me as a PANDAS case. Excuse me. And he was on Prozac and did not change the medication, as he was an out-of-state patient, and so he came for a integrative medical consultation. At age 12, he was hand washing over 40 times a day, fears being touched, pulling his hair, old objects in transformation if he touched an object. Many of these started after the swine flu news media exposure. He had very good behavioral therapy. Decided somewhat, but then came full back after that. This I didn't have the testing, so let's go to this slide. But anyways, this individual, we're able to do all three things. The testing for the case of morphine was negative, but he had significant deficiencies in magnesium, zinc, and we did two things. We increased the Prozac to 40 milligrams and used the 5-HTP, the enhanced effect, as well as the nutritional supplements, and he's someone we've been following with significant improvement as well. Pretty much the hair pulling, the OCD is almost stopped, and the hair pulling has gone from a disabling illness to very, very mild. And then this also was someone who presented as having PANDAS. And I guess the message that I want to share to the group tonight is that too many of the patients that I'm seeing and that I'm speaking to over the phone that our families are being treated and looking at PANDAS, they are forgetting that the majority of the parents and the families have genetic histories to OCD. So I believe there's a vulnerability to OCD that is getting hugely neglected. And the PANDAS treatment is not always eliminating the OCD. There's been often an exacerbation of OCD in tics, and I see the tics get better, but the OCD predated the symptoms, I would say, in over 50% of the patients that are calling saying they have PANDAS. So PANDAS in treating the strep can be important with antibiotics, with IVIG if needed, but too many of these parents, many of them have OCD themselves, are so over-focused on the infectious etiology, they forget two facts that are striking. One is the OCD started way before the onset of strep, and two, the family history of OCD. This is one example. He was treated for PANDAS out of state. He received antibiotics, steroids, minimal improvement, and he also did not have HPHPA, and he did not have elevated cases of morphine. But look at this organic acid test with this dramatic elevation in these markers. That was the only intervention. Many variations of probiotics, some herbal. We did not use antifungals. This was a purely nutritional intervention. We do have the repeat testing, and what's dramatic in the repeat testings is there's still metabolites, but is a significant improvement within a brief period of time looking at probiotics, Saccharomyces, and DPP4. So hopefully I convinced you that there's not a one test, one treatment modality for OCD. There are many, many different ways that the neurochemistry that I believe is genetically handed down can be affected. And medication is often required, particularly in my older patients. Often with children, we can use these integrative interventions. With our adults, oftentimes I need to use medications to break the cycle. And by breaking the cycle, I mean that these intrusive thoughts and behaviors are so ingrained in these behavioral patterns that the nutritional interventions don't work unless I can decrease those behavioral patterns. And the reference EEG, many of you have heard me talk about in the past, is just one tool that I've used that I can help predict which medications, because just increasing SSRIs to high doses rarely help. What we're looking here is the QEEG, unmedicated, as compared to other patients, not their diagnosis, but their EEG, and a database has been collected over 20 years to help predict medication response. This is a test done out of a company, California CNS Response. The problem is insurances Some insurances are covering it after a failed medication response, but many aren't covering it. So it's an out-of-pocket expense. The company is CNS Response California. We do this in our office, and it just guides medication response when you need it. So to summarize, OCD is common. It is underdiagnosed and undertreated. I believe the statistics are way underreported, because in the old days this used to be called the secret disease. There are many patients that we're seeing where treating the young child and the parent has the disabling OCD in one aspect of their life, but it's never been treated. They didn't even know it was a disorder. So often, as you start looking more carefully, you'll be able to find it. I found the most help to be with the amino acid supplements, SeroPlus in particular. In the beginnings, carries this pure line, and it is the simplest place to start. I think it can be used as an augmentation strategy with medications as well as by itself. Everyone is different. I wish it was simple. It tends to be complicated. With a biological base, aggressively looking at these nutritional supplements, looking at their organic acid and peptide tests, looking for B12 and other deficiencies, we get a biological base where then some of our CBT and behavioral therapies become much, much more meaningful. So I'm going to end here. You can reach us at our webpage. If you have any specific questions, anything we can help you, I encourage you to sign up on our webpage to get mailings as to emails as well as upcoming webinars. And in the depression book, where I outline this integrated medical approach, I believe is also critical to understanding OCD. Many of these nutritional programs are outlined in the depression book.